events.
Good evening, everybody. I'm really happy to be here. It's an honor for me to be in this event. My name is Vela Jarquin. I am a biomedical engineer turned AI researcher from Mexico City, and I am deeply convinced of one thing. The greatest potential of AI doesn't lie in understanding data, but in understanding who we have allowed ourselves to leave behind. 2 years ago, an algorithm I helped build quietly flagged an overlooked patient file. That single alert set off a chain of events that saved a young mother's life. I'll share her story in a moment. It reminded me that artificial intelligence isn't just lines of code. It's a bridge we can use to reach patients and clinicians who have been standing on opposite sides of healthcare divide for far too long. Today, in the next few minutes, we will explore how AI can move from isolated success stories to systemic impact. Across languages, regions, and resource levels, we'll look at concrete cases, emerging technologies, and most importantly, a human-centered roadmap for making doctors, engineers, and policymakers succeed together. So let's begin this journey, from these polls on the screen to every corner of the globe. Picture this chart. Buried in 40 pages of clinic notes, there's a single line. Uncle, heart attack at 42. For years it sat unnoticed, while Maria, a 34-year-old mom from Oaxaca, was told her cholesterol level was just a bit high. She kept working 2 jobs while raising a 5-year-old. Then our AI model ran across her entire history. It stitched together that stray family history note, lipid panels, and tiny deposits the resident had recorded as skin tags. The algorithm screamed familial hypercholesterolemia, an inherited condition that strikes 1 in every 300 people. Yet, fewer than 10% ever hear that word from a doctor. We began aggressive therapy, and today Maria is running after her daughter instead of lying in an ICU. Why does this matter? Because an 88% accurate machine learning model from Stanford showed we can surface thousands of hidden FH cases just by reading the data we already collect. Across the globe, similar silent killers slip through the cracks daily because nobody had time to connect the dots. Before diving deeper into algorithms, let's anchor ourselves in the problem that we are trying to solve. First of all, access. This map over here shows 4.5 billion people who still lack essential health services. That's every other human being on Earth. Problem number 2, workforce. Even where clinics exist, there often isn't a clinician. The World Health Organization projects a shortfall of 11 million health workers by 2030, concentrated in low and lower middle income countries. And finally, money. While resources pour into health, they pour unevenly. Just 16% of the world's population, mostly in high-income nations, consumes about 80% of global health spending. The remaining 84% share the leftovers. If our solutions only work for well-digitized hospitals, we are baking inequity into the next generation of healthcare. The question for the rest of this talk isn't, can AI diagnose better? We know it can. The real question is, can we design and deploy AI so that a nurse in rural Chiapas or an internist in Warsaw can leverage the same cutting-edge insights as a specialist at Stanford? With that challenge in mind, let's look at where AI is already making cracks in this wall. Let's test our ambition against one of the world's oldest killers, tuberculosis. In rural Zambia, patients queue outside a mobile clinic with a single portable X-ray unit. Last December, researchers ran an AI algorithm from a laptop on those images. It hit the World Health Organization's bar of above 90% sensitivity and 70% specificity and matched the accuracy of 9 radiologists across nearly 2,000 cases, many co-infected with HIV. But why is this huge? Zambia has roughly 1 radiologist for every 200,000 people. This model acts like an always-on specialist that never asks for overtime pay. But what if you don't even have an X-ray? A brand new study in Benin swapped photons for sound waves. A nurse ran a handheld ultrasound across patients' chests. An AI nicknamed Ultri interpreted the scan in real time. It nailed 93% sensitivity and 81% specificity, 9 points better than expert sonographers, while meeting World Health Organization's target for non-sputum tuberculosis triage. The key takeaway is that both systems run on commodity hardware and an internet link thinner than a tweet. They are proof that cutting-edge AI can leapfrog missing specialists and heavy infrastructure. But raw accuracy isn't enough. Rolling these tools out requires three things that don't fit on a high-end NVIDIA GPU. The first ingredient is local data. This will help avoid algorithms that think every scan is a textbook case from Boston. The second one, training nurses on the workflow, because great tech fails if a probe angle is off by 2 degrees, or if the leading doctor refuses to change his procedures. And finally, regulatory buy-in. Zambia's health ministry allowed the tool use before a single patient result was shown. This blend of smart code and smarter collaboration is the pattern we'll keep seeing as we tour real-world AI breakthroughs. If tuberculosis algorithms are our AI clinicians, then conversational agents are our AI concierge. What you see on the left side of the screen really happened. A patient from a US safety net clinic texted, "No tengo dinero para el taxi. Can I move my appointment?" In the old world, that message never reached a human. The patient simply didn't show up. With the new Care Message AI, every free text reply, slang, typos, and even Spanglish is parsed, classified, and routed. One clinic alone recovered enough appointments to slash its no-show rate by nearly half. And across 400 or more safety net organizations, the system is driving 45 to 50% reductions in missed visits, freeing millions of dollars that can now be reinvested in care for low-income families. Now looking at the second picture. In oncology, a Penn and Mass General team piloted a chatbot called PennyGI. It checked in with patients on oral chemotherapy, tailored dose reminders, and flagged side effects in real time. The bot issued over 3,800 medication messages and got the instruction right more than 90% of the time, while patients rated it reliable and easy to use. Why does this matter? Because a WhatsApp text costs fractions of a dollar, works on a 2G network, and speaks the patient's language instantly. In my own work at Mexico's National Institute of Nutrition, we have developed similar bots for diabetes follow-up. To everyone's surprise, the biggest hurdle wasn't fine-tuning a transformer. It wasn't even using GPT-4. It was actually convincing old-fashioned doctors that an emoji field reminder could coexist with clinical judgment. However, once these doctors saw people reporting on their meals, they became the bot's biggest champions. Here we can find an important lesson. Conversational AI succeeds when it tackles real human barriers, transport, confusion, fear, and when nurses, pharmacists, or community health workers co-design the scripts. The tech parses the words, but people still parse the life and knowledge behind the words. Next, let's explore the frontier where generative AI starts acting like a consult room colleague. Lately, headlines love to induce fear or hype and announce, "Beware! AI is coming for your stethoscope!" But is this real? Let's swap headline heat for data. I want to introduce you to Amy, a research AI system developed by Google and published in Nature. What you're looking at is a 302 case benchmark of the toughest diagnostic puzzles lifted straight from the New England Journal of Medicine. I want you to focus on the top bar. Amy, on its own, lists the correct diagnosis somewhere in its top 10 choices more than half of the time. But that's not impressive, right? What if I told you that clinicians reading that same cases, unassisted, barely hit a third of the cases? Now glance at the Sankey diagram on the right. Here is where the magic happens. When those same clinicians get Amy on their side, their accuracy jumps from 36 to 52%. The model isn't a rival. It's a second set of eyes that resurfaces blind spots at 3 a.m., even on a ward with no subspecialists in sight. Now, raw accuracy is only half the story. The other half is what I call the tropicalization problem. What happens when code written in Cambridge meets real-world language, bandwidth, and workflow? I'll give you an example. On the left side of the slide, we can see a real Mexican voice note. El paciente presenta un rash eritematoso en el tórax. The speech-to-text system translated this as El paciente presenta un rash erythematosus en el tórax. Suddenly, our erythematous chest rash has turned into a salad ingredient. Clinicians laughed, but the chart was wrong until somebody spotted a typo. The table shows that the erythematous problem is systemic. In the Health QA benchmark, GPT-4 offers more comprehensive and appropriate answers over 1,000 times in English, but only 891 times in Spanish. And contradictory answers spike more than tenfold in Hindi. The lesson is, if the dataset speaks only Harvard English, your algorithm will too. Whenever teams pilot Spanish dictation in real clinics, 3 patterns surface almost immediately. First of all, dozens of regional pronunciations for common terms like ampolla or blisters in English. Low bandwidth or low quality headsets that swallow consonants whenever the 3G signal hiccups. And finally, you won't believe it, but clinicians who push back until the software stops botching their names or accents or get the exactly correct things on their notes. What gets traction isn't a larger GPU or a diffusion-based LLM, it is frontline partnership. This is my recommendation. First, get a local clinical champion who helps you understand the system and how medicine is actually practiced there. From local abbreviations to the unspoken rules, knowledge that first-line treatment may be out of stock or that everyone knows that ultrasound tech only works in room 2. Second, get an informatics engineer who iterates with the team in real time, tuning prompts, adjusting thresholds, and fixing bugs before they go stale. Finally, get a nurse or care coordinator who sees what physicians often miss. How do patients describe their symptoms when no one's looking? When no one's holding a clipboard? How workflows flex during shift changes, understaffing, or informal workarounds? This trio turns large language models from black box guessers into useful collaborators because they tune not just the model, but the context it is stepping into. And once the adaptation happens, trust rises, usage climbs, and the hairy tomatoes vanishes from the charts. We've talked about brilliant local solutions, but what if we want one truly global model without shipping patient data across borders? Enter federated learning. What you see here is the methodology used by the SAM project. 20 hospitals from Boston to Bangkok kept their data inside their firewalls. Instead of moving data, they moved encrypted model weights. Each hospital trained locally, then shared only learned parameters. A central aggregator merged the knowledge, sent it back out, and the cycle repeated. What is the payoff? A model that could predict whether a COVID-19 patient would need supplemental oxygen within the next 24 to 72 hours, with an area under the curve score greater than 0.92. And crucially, it performed 16% better and 30% more consistently than models that any single hospital could build on their own. Why else is federated learning so interesting? Well, first, it has inclusivity by design. A hospital in Madrid can contribute its data signature without violating privacy laws or needing a 40 terabyte transfer. Then it is robust. Training on diverse demographics means fewer surprises when the model meets a patient who doesn't fit local patient types. And then there's trust. Clinicians and regulators are more willing to adopt AI that never exposes raw patient records. Up to now, we have celebrated algorithms. But here's the harder truth. Most AI pilots don't die because the model misses a decimal point. They die in the handoff between technology and people. Take a quick look at the 4 icons on the screen. They represent 4 common problems. The first one, lost in translation. A clinician says Sado88 and the data scientist hears saturated dataset. Neither is wrong, but both are confused. Second, paper first. What if I told you half the planet's outpatient notes still sit in paper folders? So no amount of transformers or fine-tuning can read ink that hasn't been scanned. Then we have wrong incentives. Imagine a nurse that gets graded on how fast she clears triage. An extra AI pop-up is a nuisance for her, not a miracle. And finally, no feedback. If the pilot ends and nobody tracks whether outcomes are moved, the model drifts quietly into our forgotten Docker container. These are the human bottlenecks that sink promising code. So we built a playbook for these problems. We call it TEAM. T stands for translate. Pair every sprint team with a bilingual translator, but not Spanish to English, clinical to technical. E is for equip. Before AI, digitize. That might mean low-cost OCR for paper labs or solar-powered Wi-Fi hotspots. A is for align. Incentives beat algorithms. We promise nurses that the chatbot will reduce midnight calls, not add tasks. We secure a policy memo so IT gets budget to maintain the server even after the pilot glamour fades. M is for measure. From day one, define a two-sided scoreboard. Of course, clinical outcomes, but also workflow happiness. This formula works because it tackles the human bottlenecks first. When doctors feel heard, when engineers see real-world constraints, innovation accelerates. In Mexico, we've only just started. One hospital, a retrospective scan of 6,000 charts. But even that small step surfaced 70 previously missed cases and convinced the chief of service to back up the project. And here's the takeaway for builders and backers in the room. The capital that wins is the capital that funds relationships, not just GPUs and tech. Entrepreneurs and VCs in the room. This slide is for you. On the left, we have the moonshot. No collaboration. IBM poured $4 billion into Watson for oncology. Without deep partnerships in hospital workflows, it delivered unsafe treatment suggestions and folded in 2023. DeepMind's brilliant kidney injury app stalled when clinicians and patients learned their data had been shared without their consent. Great tech, but thin relationships. Zero impact. On the right side, we have the smart shot with high collaboration. Look at CAV4TB. At 200 computer box deployed in Zambian and Indonesian clinics, it runs a compressed model offline that local nurses helped spec out, and it manages to read X-rays at a precision of 99 ROC score. Or the diabetic retinopathy unit piloted between Guadalajara and Sao Paulo, a portable camera plus open source algorithms that screens eyes in 8 minutes for under $5. 30,000 patients touched on a $250,000 grant. The pattern here is very simple. Advanced tech without trusted collaborators bleeds capital. Modest tech with deep local insight scales really fast. This journey is coming to an end, and we have traveled from a single life saved in Oaxaca to algorithms spanning 5 continents. But none of this matters unless it turns into action. Your action. So here's my invitation. Run a bias audit. Choose one model, radiology, conversational AI, logistics, and test if it truly serves all of your patients equally. Join or start a federated consortium. It doesn't take millions, just an email thread and a common goal. Adopt the team formula. Translate, equip, align, and measure. Make those 4 words your blueprint. Open source something. A pre-processing script, a multilingual glossary, or a simple lessons learned memo. Generosity scales faster than any funding round. Mentor across boundaries. Pair a data scientist in Bogota with a clinician in Berlin. Have a nurse from Mexico City critique your next UX design. Because the real story of AI isn't written in Silicon Valley offices. It's unfolding in clinics like yours. driven by clinicians and developers exactly like you. It begins with the moment you decide your constraints are the very reason why your innovation matters. Wherever you are with whatever resources you have, this is your moment. Not just to build AI, but to feel the AGI in your everyday work, actively transforming care. One patient at a time, let's make our story one worth telling.